Yes. Hello, everyone. Yet another session of webinar today, and I welcome everyone in today's forum. Today, this webinar topic is on infusion-related phlebitis, detect and treat early. Myself, Shanti Bhattacharya, the VP from Yashoda Hospital, VP Nursing from Yashoda Hospitals. Why we have chosen this topic today for discussion is because the patient's very common discomfort and distress is nothing but pain and pricks. Despite of having the acknowledgement of the fact that we have top-notch cutting edge of technology, but one cannot refrain from pricks, pain during the hospitalized stay in modalities of therapeutic treatment because they take a lot of infusions, blood products, high risk medications, etc. And it is very challengeable for the bedside nurses also that maintaining the IV post-phlebitis infusions and doing the catheter insertion without failure also is very challengeable for the bedside nurses. So let me introduce the very eminent speaker. The panel expertise is Dr. Swathi, who is Dr. Swathi Prakasham, who is our consultant microbiologist and infection control officer from Somajiguda, Yashoda Hospital. I welcome you, ma'am, in this today's forum.
Thank you.
Dr. Swathi is not only mentors the nurses, rather she's responsible for in developing the hospital policies and procedures, and she's a very good trainer and auditor and mentor as well. Also, let me welcome our infection control nursing supervisor, who is a Fabina, and she's giving the guidance for all the 4 units. I welcome you, Fabina, for today's forum. And having said so, the forum is over to you, Fabina. You can start the session.
Thank you, ma'am, for introducing me. Good evening, Dr. Swathi, ma'am, and good evening, Shanti, ma'am, and to all my dear viewers who are watching this webinar. First, I would like to extend my gratitude of thanking my management for giving me this opportunity. As you'll know, today's topic is infusion-related phlebitis. How do we detect and treat it early? So what is phlebitis? What is phlebitis? Phlebitis is an inflammation of vein which results in redness, erythema, and swelling along with pain. What is infusion phlebitis? Peripheral intravascular catheterization, which is commonly introduced for the patients who are hospitalized for the use of administration of medications, fluids, bloods, and blood products. This condition may be recently using an IV line and after trauma in the vein. What is infusion phlebitis? It is due to one or more blood clots in the vein that causes inflammation in the body or in the part wherever the IV catheter is being inserted. Phlebitis can occur both the surface and superficial or deep vein.
So my question to Dr. Swathi is, why do you think this phlebitis, because we keep looking at our quality indicators and all the time we have this growing issue that it is a bit underreported. What do you think, Dr. Swathi, and what could be the reasons? Is this the same practice everywhere?
So what I feel personally after seeing with our infection control nurses or talking to most of the nurses, they feel it is a personal responsibility or it is a mistake which has caused the phlebitis. So sometimes it may not be, every time it may not be the scenario. So they want to, it's a tendency to So just to, they feel it's a mistake done by them. That's why they want to hide it. So that's a major reason for getting underreported. Maybe it's not always the reason, or it's not always the nurse's fault or someone else's fault. It has been inserted in wrong vein. They have to understand it is a process, or it is some complication which is common to any other in device which is placed, not only peripheral line, it could be any line. So every line in the body can cause some complication, and phlebitis is one such complication which could be avoided. That's the only thing they have to emphasize on. But just I feel it's underreported only because they feel it is some mistake done from their end. That is one major reason I find they want to not report such scores. That is what I filed when I find out when I'm interacting with most of the nursing staff. And it should not be like nurses are also getting, accountable for it. Sometimes, some scenarios, yes, nursing, the person who is giving care is accountable, but not all the scenarios we are the same. So we should also, the person who is looking into this phlebitis as a quality indicator or taking them as a final, should actually do a proper root cause analysis before, what is the actual cause for this phlebitis. Then we can improve the process also so that the incidences will come down.
Absolutely, yes. Yeah.
Thank you, ma'am. As per the INS, that is Infusion Nurses Society, it is estimated that 13% to 56% of the hospital admitted patients are prone to get phlebitis. So let's see what is thrombophlebitis and the causes. It is due to one or more blood clots in the vein that causes the inflammation. The thrombus vein causes pain and irritation and block flow in the vein, which can occur both surface, that is superficial, or deep vein. So let's see the differences and the signs and symptoms of phlebitis and thrombophlebitis. It's mainly on the subjective and objective data. That is, phlebitis can be with redness, fever, pain, swelling, and there could be breakdown on the skin. Thrombophlebitis, the red, swollen, and irritated skin around the affected area, and a swollen vein that feels like a tough cord under the skin. What are the types of phlebitis? Basically, mechanical phlebitis, which can be due to the friction with the wall of the vein, chemical phlebitis, which is due to the medications and their osmolality and pH, and then bacterial phlebitis due to the presence of infection bacteria.
So, Dr. Swathi, again, if we would like to know your insight on like IV cannulization or catheter insertion by the nurse when is a very tough and risky situation, because all the patient who comes to the hospital is very sick, and because of their vulnerable age and their fragile and disease condition, the anatomical features of the vein may not be suitable. And you can imagine the nurse who is in the room and there are a lot of family members around. This is a challengeable situation. And what logics or what tips you would like to give to the nurses? Because here the breach of transparency on the procedure also is important when we do such evidence-based procedures.
So first and foremost, the nurse who is doing it should be confident enough. Secondly, they can use, now we have technology like vein scanners, which we are already using in our hospitals. If they put that vein scanners to good use, I think they can do it in single prick. If you go further, there are some developments. Currently, we are not being used. They're like, you have like BD Venflon, you have a technology called InstaFlush technology. So once you keep it, you need not go through a different, a mile of, if you generally in the normal cannulization, what happens, you need to enter a vein a little bit and then only you will get the backflow and then you have entered the vein. But with this technology, what happens is once we hit the vein also, there is an indicator which says the needle is in the vein. So your manipulations will come down and you need not push and pull, and the pain to the patient will be little lesser. So basically with the existing ones, maybe we can use vein scanners more to use and choose a proper vein, so that we not, based on the infusions the patient is expected to have. So the nurse has an idea how many infusions the patient has to be given. So based on it, if she chooses a proper vein, not using a thinner vein or a branching vein, will also help us to reduce the incidence and repeated pricks to the patient.
So what could be the reasons, as you have said about the technology of InstaFlush, BD, Menflon? What could be the reasons of these mechanical, chemical, and also for the bacterial phlebitis? You think the sole reason for the bacterial phlebitis is only single reason, not washing the hands, or any other contributing factors which is not been adhered or practiced to?
See, bacterial phlebitis can occur when we have not disinfected the skin properly at the time of insertion. That is one more thing we have to be careful. And secondly, during insertion also, when we are doing the disinfection, we have to make sure the disinfectant has dried enough. That is one of the major causes of chemical phlebitis. We may think it is solutions. Yes, solutions are a part of it. But when you are inserting and you don't let your disinfectants, like whether you're using chlorhexidine or using spirit, you're using alcohol swabs, for example. So there, once you puncture it, there is a chance these chemicals will enter the vein. So you have to let the disinfectants dry properly, and that disinfection should happen properly. So good, you don't give that, when you prick the skin, the portal of entry, at that time you don't have bacterial colonization on the skin when you're pricking it. That is one of the reasons where, mostly bacterial phlebitis can occur. Second reason is manipulations. Number of manipulations, people handling the line, and, we have to try to minimize this. Too much of handling of the lines may also cause, that mechanical push and pull of the veins during this handling will also cause phlebitis. So all these things we have to be a little careful while doing it, especially when the patient is expected to have that line for a longer time. So I feel the disinfection of the skin during the insertion also makes a difference. And chemical phlebitis can occur because you have left, you have not let the disinfectant dry enough, and you are picking it when it is wet, and the disinfectant still is there on the skin. Mechanical phlebitis can be reduced if you are, handling the lines a little carefully, and when we are inserting, when we will not do multiple pull and push. So all these factors, if you are careful, maybe we can avoid patient progressing to phlebitis.
Fair enough, Dr. Swathi. Over to you, Fabina.
Yeah, ma'am. So, post-infusion phlebitis, how do we know that? Post-infusion phlebitis is normally appears after 48 to 96 hours of removal of the catheter, which can contribute for, as already we explained, mechanical factors. It could be chemical factors, infection factors, and as well as patient factors, like if the patient is already having an infection at other side of his body. How do we detect it and do the assessment and do the observation for the phlebitis? It's with the VIP scale, where we do our VIP scoring depending upon the signs and symptoms of the phlebitis. So immediate nursing intervention for phlebitis should be mainly the hand hygiene is the utmost important component to be followed before and after any procedures for the patients and anybody. The phlebitis is mainly treated based upon the severity of the grading. Like if it is a mild phlebitis, 0 to 1, revert without treatment. And the grade is 2 to 5, moderate to severe phlebitis. Immediately stop the infusion and remove the cannula. Monitor the patient's signs and the IV site for any kind of inflammation. And if it is inflamed, please elevate the inflamed area and apply the warm and moist compress over the site, which can minimize the inflammation, and do the documentation and monitoring for the root cause analysis, and do the corrective and preventive action with proper documentation of patient condition and interventions.
So here the concept of applying the warm, moist, hot and cold applications, because we see nurses, sometimes they are not able to select the proper and the right kind of compression once the patient has developed post-phlebitis, on when they or when they receive the cannula. So what kind of compression they should apply when we have witnessed a post-infusion phlebitis, and against what type of phlebitis?
Actually, if there is a swelling, the study says the cold compressions will help because the coldness will constrict the veins and the blood supply will be little decreased. So the swelling also will come down with the shrinkage of the veins. So mostly when you in your score, if you are seeing only swelling with no erythema or anything or local rise of temperature, means the phlebitis has not yet set into an infection, then you can mostly go with cold compressions. But most of the studies when I was referring to are comparing, when there were comparative studies between moist and cold, they have actually not found much difference. Patients were responding in most of the way. But when there is only visible swelling, they are advising to go for cold compressions because of this background of shrinkage of veins and reducing the swelling. So both moist and cold will suffice. Not a warm swelling or a very hot fomentations will not help in case of phlebitis. It should be a moist heat or cold. Over to Fabina.
Yeah, ma'am. So when the documentation part and the root cause analysis and the preventive and corrective action is being taken, please keep the family members also informed about the temporary discoloration, bruises, and the signs and symptoms which can be affecting due to the phlebitis. The precautions what we can take to prevent the phlebitis are mainly inserting the catheter site is very important. Use the vein scanner, as already Dr. Swathi ma'am has told. Use a proper illuminated and ventilated environment before inserting the catheter. And then as in assessment of the peripheral line dressings and splints per shift is very important. Infusion of the pump pressure is also can be manually increased with the clinician's order. Administering the drug, volume of diluent, required dose and flow rate is also important, which we can take a important precaution. Then flushing of the peripheral lines using a pulsatile flushing technique is important. Flush the catheters immediately after placement and after every medications are being administered and before administering the medications. Using of the boards, splints are recommended to secure the peripheral lines, especially for the pediatric cases, and as well as when the lines are set in the joints of on the limbs.
So here, if we talk about the flushing technique or the protocol, I'm sure we do the flushing protocol, otherwise we will not have the patency of the vein, and almost we will be trying every day, ending up in pricking the patient. So is, as per your insight, is the flushing protocol safe, and if at all it is safe, with what product we need to flush or what kind of solution we need to use, and how frequently we need to do this flushing technique?
Flushing protocol is required so that we are making sure the vein is patent, as you all know. So flush, mostly we use normal saline flush or heparin flush based on the clinical condition of the patient, and it's based on the type of line. Usually we do mostly use normal saline flush, as all of you know. But only thing, when we are using flush, the saline which we are opening, it should not be used for a longer time. That is one thing we have to make. You can't keep the saline open for 1 day or 2 days and keep on using the slim flush. So we always recommend the people or the staff to use 100 ml NS and don't puncture it at the sites, puncture it at the cap where you can recap it, and discard the flush, that particular NS at the end of the day, as that is compulsory. I mean, it has to be done so that the water will not act as a source of infection. Secondly, we have to do flush before accessing the line and between drug to drug to clear the drug of the previous drug. So when you are having 2 different drugs, so before you keep the second drug, it is recommended to flush. And when you are doing the lock therapies, so this is before lock therapies also, we just give a flush and then go for lock therapies. Lock therapies are not mostly used for the lines where we have we have no other option. So that line has to be somehow put there. So these are the most common times where we have to access for flush. So better if you keep flushing it, we know the patency, and that is one more, and that you have to be careful. If the vein is colonized, if you are seeing any sign of phlebitis there or inflammation, redness, we have to think twice before flushing, because maybe the line or the cap, the plastic vent which you keep inside might be colonized with bacteria. When you flush it, there is a chance you're directly pushing it into the stream. So usually when you're saying the first signs of inflammation, please don't flush it. Once you flush it, we don't know what is the state of the line inside what is the state of that plastic, thin plastic tube inside. It might be colonized already with it, and you are flushing it, the bacteria goes into the bloodstream. So if for a normal vein, which is not having a fitting into your VIP score 0 or 1, you can do it. But once you have your scoring into practice, or you're seeing 1 or 2, better not do these flushes.
Over to you, Fabina.
So let's see, the complications of phlebitis are infection, which is skin-based bacteria may enter through the incision site, vein irritation due to the presence of the catheter or the fluids or medication, and infiltration. To conclude, with my conclusion, phlebitis is an important ongoing bad experience faced by the patients who are hospitalized. So we can avoid by pricking only once, and if you're not sure, please ask and help from your seniors or the anesthetist. It is said, constant attention by a good nurse may be just as important as a major operation by a surgeon. Thank you.
So, Dr. Swathi, you think every day eye detail assessment by the nurses when they take over would be very well practiced enough so that we will
not progress further, and we can take an early call, and the patient will also have lesser trauma. So better we do that scoring. VIP score is a very important and a very useful score which is in place, which we are already practicing. So if the nurses can follow it diligently, it will save a lot of pain to the patient also.
Thank you, Dr. Swathi and Fabina. I think VIP score protocol itself is a audit tool where we can witness the grades and the sign symptoms against the patient's swelling. So I think this, if we follow properly, I don't think there will be phlebitis, of course, but then patient do not have to take a lot of pains, and all the often we do not have to do reciting the cannula. Thank you so much, and stay safe. Next week again we will connect. Thank you.
Thank you.
Thank you.